All right, good evening, everybody. Thanks for coming out. Such a windy evening and hard to believe. Can you hear me okay? Let's move this a little bit closer for Anthony's benefit as well. Oh, can you hear me now? Oh, okay.
Yes, thanks.
Okay, great. Thank you online. And yeah, if you have any questions or AV issues, please type them into the chat and we'll be monitoring that and can address them if they come up. So before we get started, I just wanted to remind people once a year or so, I think I try to remind people, but if you ever have leftover medications, especially HIV medications, I know we often have to change our meds and stuff and end up with a stockpile. Please don't throw them away. There's a clinic in Tijuana that relies on those. There's doctors at UCSD who gather them from their clinics in San Diego, and I bring them from Palm Springs, and they supply, I think, two different clinics down there. They're run entirely on donated HIV medications. So, as you know, these things cost a lot of money. There's no way you can, send them back. You can't give them to somebody else here, technically, because that's not legal. So, but you can donate them to be used abroad. So, if that ever happens, let me know. I'm actually going to be going down to San Diego mid-month, I think on the 14th. So if you have any you want to dispose of and like to see go to a good use, let me know, and we'll take them down. Jim, a question? Yeah, if they're recently expired, they can be opened. The expiration dates are kind of a suggestion, not a. It's not like they're not good. It's not like spoiled milk, right? As long as they've been stored, in a moderate temperature and not too humid, most drugs will be fine. So yeah, done.
The HIV medication?
Commonly used, somebody was just asking me that question. So commonly used drugs for other things like diabetes and so forth would be okay as well. What I do is just anything people give me, I take down there. And if they can't use it, they toss away. They ask not to, they don't want to accept scheduled drugs like, Vicodin and things like that because there's too many issues around that. But other commonly used medications as well as HIV medications. Yeah. Yep. Good stuff. Save your doxycycline for PrEP and PEP. I don't, this is kind of informal. It's not a formal program. So there isn't a flyer, but spread the word and just give it to me and I'll make sure they get to the doctors in San Diego. Yeah, exactly. So I know people have been watching the news. It's been a bad day for the NIH. A lot of colleagues I know and work with have been fired. So we're just gonna have to wait to see how the dust settles, to see how that affects everything. But a lot of research is being affected. The main clinical trials research group, the ACTG, has put a freeze on enrolling new patients into any of their trials. They haven't lost their funding yet, but it's uncertain, so they didn't want to put more people on trials. So all the HIV trials have been halted for enrollment. I think the TB trials are ongoing. That's a big killer in Africa. So that's good to hear. I think they may get funding from a different source for those, which is why. But I'll keep you posted, as we hear more. But right now, it hasn't affected any of our funding for HARP here in Palm Springs, and knock on whatever, hopefully but that could change at any moment. So that's all I have to share from there. And we're excited tonight to have soon to be Dr. Anthony Velasco from DAP, who is our HPV guru as well as director of trans health at DAP. So Anthony, welcome. We're looking forward to your talk.
Yeah, we should probably how long do we have?
We have until 8 p.m.
I'm fine with if people have questions throughout the presentation, that's fine with me.
Have to rail your talk.
No worries.
Questions during the talk and then more details after.
All right, good afternoon, everybody. Thank you. Again, I'm Anthony Velasco. I use he, him, and they, them pronouns. I'm the Director of Gender Health and Wellness Services at the AP Health. So I oversee our transgender health services as well as our high resolution endoscopy services. I've been in HIV care for the past 15 years and have been doing high resolution endoscopy anal cancer screening for the past almost decade now. So I hope that our presentation today resonates with all of you, and I hope you get to learn something about anal cancer screening and how we can prevent anal cancer as well. So let's start first with the anatomy. It's very important to understand where the anus is. Oftentimes we conflate the rectum and the anus. They're quite different parts of the body. So the anus is this green rectangle over here. So it starts at the anorectal ring on top and then down to the anal verge, which is the opening of the anus. So when we really think about the anal canal, it's a really short canal. It's only about 3 to 5 centimeters or about 1 to 2 inches. So how common is anal cancer? So it's actually a very rare type of cancer compared to other types of cancer. So for instance, in 2024, there were about 11,000 new cases of anal cancer in the US compared to the 154,000 new cases of colorectal cancer in the US. It's also a very rare cancer for people younger than 35 years old. And we typically see this type of cancer among older adults. And when we look at the median age, average age of diagnosis is usually diagnosed in the early 60s. However, later on, we're going to talk about some risk factors, and we'll see that certain conditions, HIV, for instance, the average age for anal cancer typically is younger, so it's usually in the 40s. It's also more commonly found among women than men, which is very interesting. About 3,000 new cases in men versus about 7,000 new cases in women in 2024 in the US. So I think we're doing such a poor job in screening cisgender women. So definitely there's still a lot of things that we could do better. So what is the trend for anal cancer in the US? We have seen anal cancer cases. It has been rising in the past several years. In fact, between 2001 to 2015, it has tripled. We see this more so among men who have sex with men, regardless of their HIV status, and men and women with HIV. We also see a lot of anal cancer. There's a lot of health inequities among people of color, and I think that's probably because of poor screening among that population group. There was a study that was done when we look at missed opportunities, and of those people who were diagnosed with anal cancer, we saw that about 44% of them miss opportunities for early cancer screening. So again, a lot of things that we could improve in. Um, I think I mentioned about how it is rare among people who are younger than 35. Again, it is more common among those living with HIV. We see that HIV seropositivity, meaning people living with HIV, have an increased incidence of anal cancer among men and women. And again, more common among women than men. So I think one of the reasons why this is also oftentimes missed is because of the signs and symptoms of anal cancer, and it oftentimes mimic benign conditions, meaning non-cancerous conditions such as hemorrhoids, for instance. Sometimes anal cancers are also asymptomatic, so it doesn't show symptoms for many folks. And if symptoms occur, bleeding is the most common symptom that comes out first. And oftentimes bleeding is very minor, so a lot of people just, oh, I have a little bit of blood in my toilet paper, it's gonna go away. But if something like that were to happen, it's very important for us to inform our primary care provider or specialist that that is a symptom that you're experiencing. So again, some of the symptoms associated with anal cancer: bleeding, itching, very common with hemorrhoids. There's also going to be a change in the caliber of the stool. So the stool becomes like pencil thin. That's typically an indication that there's a blockage going on there. That's why it's thin. Sometimes people may have a feeling of pain or fullness in the anal area. When they're feeling the backside, sometimes folks may feel an abnormal lump and bump in the anal canal. Some people may have abnormal discharge like mucus or some sort of discharge that's not necessarily related to an STI. And people may have swollen lymph nodes. And the lymph nodes that typically would be swollen would be inguinal lymph nodes. So that would be the lymph nodes kind of like close to where your groin area is. So what's the relationship between HPV, anal dysplasia, and anal cancer? So approximately 91% of anal cancer is caused by oncogenic strains of human papillomavirus or HPV. So when we say oncogenic strains, that means strains that are related to cancer, right? Cancer producing strains. Among cisgender men, meaning men who are assigned male at birth, who identifies as men, the incidence is highest among men who have sex with men with HIV compared to those who are not living with HIV. For instance, among people living with HIV who are men who have sex with men, the incidence is about 131 per 100,000. And then in comparison, it's only about 46 per 100,000 among other men with HIV, and then 2 per 100,000 among those who are not living with HIV. So there's that big difference among that population group. Same thing among cisgender women who are living with HIV. We find that cisgender women living with HIV, the incidence is much higher than those who are not living with HIV. And then among transgender women, the incidence is also high among those who are living with HIV. So it's about 70 per 100,000 versus those who are not living with HIV, which is about 18 per 100,000 between ages of 45 to 59 and more than 34 per 100,000 among those who are 60 years and older. So again, there's that big difference between those who are living with HIV and those who are not. Unfortunately, we don't have data on incidence among transgender men or non-binary individuals living with or without HIV when it comes to anal cancer. So when we think about progression from dysplasia, meaning abnormalities in the tissue in the anal canal leading to cancer, we believe that anal dysplasia is a precursor to invasive anal cancer. However, limited data is available to support a stepwise progression from low grade to high grade to invasive carcinoma, meaning those who are not precancers, those who are precancers leading to cancer. However, there are some studies that have documented that there has been some progression from those who had precancerous lesions in the same area where there were low-grade lesions before, meaning, if you have a lesion that was not precancerous, if you follow it, there has been some documentation where it actually progressed to precancer. In the same study, about 41% of individuals living with HIV who have low-grade lesions, meaning not cancerous lesions, develop precancerous lesions during a 20-month follow-up period. About 84% of those who have precancerous lesions at the same location, when we actually look at what those lesions are before, they were low-grade, meaning not precancerous. So having non-precancerous lesions in the anal canal, there is a possibility of having cancerous lesions in the anal canal later on. When we look at progression from precancerous lesions to anal cancer, the average progression is about 5 years. So again, timely screening, timely follow-up is critical for anal cancer prevention. Interestingly enough, and this is actually something that we've seen in the clinical setting, something that we've seen in the anchor study as well, is that there has been spontaneous regression from pre-cancer to low grade, or from pre-cancer to not there anymore. And I think one of the reasons why that is the case, for instance, in the anchor study, every 6 months we biopsy the same lesion. So one of the theories is maybe we're just actually biopsying this lesion, like basically biopsy it all out, right? So that's probably why it's not there anymore. So that's one of the theories there. But there has been some documentation where there has been some spontaneous regression, about 1/3 of the people in some studies. So what can we do to prevent anal cancer? or decrease someone's risk for anal cancer. And one of the best ways that we can do that is by giving the HPV vaccine. So HPV vaccine, it used to be the bivalent and then the quadrivalent, and now it's a nonavalent vaccine. So it protects against 9 different strains of HPV, including those who are the most virulent ones that are related to anal cancer. So what we give it 3 doses. You get the first dose the day off. 1 to 2 months after that, you get your second dose, and then 6 months from when you get the first dose, you get the third dose. So it's a total of 3. What if you already got the bivalent or the quadrivalent vaccine in the past? Revaccination is not recommended. So if you've already completed the series in the past, no need to revaccinate for the new version of the HPV vaccine. What do you do if you, for instance, you got the first dose and the second dose, and then 1 year rolls by, you forgot to get the third dose? You don't need to restart the series, you just get the third dose. I've had this question before. Some clinicians would swab the anal canal first and see if there's a presence of HPV there. And if there's HPV there, they won't vaccinate. That's actually bad practice. So you don't need to swab somebody first before providing the vaccine. It's very unlikely that an individual have been exposed to all the strains that the Gardasil 9 vaccine protects somebody. So even if you're positive for HPV, still get the HPV vaccine, yes.
Most of us are older.
Yep,
And so
recommending. Yeah, so the question was, for those individuals who are more seasoned, who are above the age of 45, is it still recommended to get the HPV vaccine? So I wouldn't say it's not recommended. There's no harm in getting the HPV vaccine after the age 45. The only caveat, the only challenge with that is insurance would not cover the HPV vaccine. So me as a clinician, what I have done, especially if my patient above 45 really wants to get the vaccine and we have a mutually agreed, decision to pursue the HPV vaccine, I would send the HPV vaccine to a 340B pharmacy, which is typically a cheaper pharmacy for my patients to be able to get the vaccine there. That's a good question. Any other questions about HPV vaccines? All right.
The question Brian White covers.
That's a good question. I'm not sure actually. Yeah, I'm not sure. I'll get the question. I'll get it to you, Jeff. Yeah, that's a good question. I'm not sure. I'll find out for you. Yeah. So the question was, does Ryan White cover the Gardasil vaccine? And the answer was, I'm not sure. But I will get the answer. I'll get the answer. So what are some other things that we can do to prevent anal cancer? Smoking cessation is very important. What we found is that higher pack year history is related to the higher risk of developing anal cancer. So pack year history is when you basically calculate how much somebody smokes per day and the amount of time that they've smoked. So for instance, if somebody smokes 1 pack per day and they've smoked for 10 years, their pack year history is 1 pack per day times 10 years. So they have a 10 pack year history. The higher that number is, the higher the risk of having anal cancer. Those who smoke also have a higher risk of having anal cancer compared to those who do not smoke. Same thing for those who have stopped smoking compared to those who continue to smoking. Those who have stopped smoking, the risk for anal cancer is lower compared to those who continue to smoke. Safer sex practices is also one way to prevent or decrease some of these risks for anal cancer. Although something to be mindful about 85% of us will have at least 1 HPV type during our lifetime. And something to be mindful about too is HPV can be transmitted through skin to skin. It just so happens that sex is a lot of skin to skin contact, right? One way that we can prevent or decrease the risk for anal cancer is by using barrier protection. So using insertive or receptive condoms. It can decrease the risk for exposure, as well as limiting the number of sex partners can reduce this. It does not eliminate it, especially if we don't know, somebody's HPV history. And again, adequate and timely screening is critical to really decrease the risk of anal cancer. Go ahead.
That on the skin contact, why accept the forms that touching a person?
Mm-hmm. Yeah, so hand-to-hand, rubbing, any skin-to-skin contact. There was a study that was done in France, where they looked at cisgender men, meaning men who were assigned male at birth, identify as male, who have never engaged in receptive anal sex, so never bottomed ever in their life. They swabbed the anal canal and they found HPV there. So how did it get there? Rubbing, washing, wiping. It can be transmitted that way. Same thing. They did a study. Can't remember where they had it. Where they I want to say it's Papua New Guinea or something. I can't remember, but where they look at people who have HPV in the cervical area, and they swab the anal canal, and they found HPV in the anal canal as well. And the reason for that is translocation, right? So a lot of people, when they're growing up, people are taught to wipe front to back. So wiping front to back, translocation of the HPV from the cervical area, the vaginal area to the anal canal. So same thing, lots of touching, rubbing can be transmitted that way. So how do we screen for anal cancer? The way that we screen for anal cancer, this is actually modeled on how we screen for cervical cancer. So again, the way that we look at this would be early identification of anal dysplasia. Again, dysplasia is just a fancy term for an abnormality of, the structure and composition of the cells in the anal canal. Again, monitoring for the disease progression, and then if we find precancerous lesions or cancerous lesions, we go ahead and do some intervention to prevent progression. The anchor study, who's familiar with the anchor study? Raise of hands. So about half of us are familiar with the anchor study. So the anchor study is this really exciting study where a lot of our guidelines actually came out of. It is a multi-site study where they recruited people living with HIV 35 years and older who have precancerous lesions in the anal canal. And what they did is they looked at is it better to just actively monitor somebody who have precancerous lesions in the anal canal versus treating the precancer? Will treating it actually decrease the rate of anal cancer? And what they found is the treatment arm, those who got treatment for anal cancer, was able to decrease the progression from precancer to cancer by about 60%. So I think our goal initially was about 7,000 patients. And when we met about 5,000 something patients, we actually stopped recruiting more because we were able to power this study to indicate that, treatment is superior compared to just actively monitoring precancerous lesions in the anal canal. And the finding of the study really highlights the importance of identifying and then treating precancerous lesions in the anal canal. It really shows how treating precancerous lesions in the anal canal can significantly decrease the risk of progression from precancer to cancer. So again, why is screening important? Anal dysplasia and invasive carcinoma are often asymptomatic, meaning it oftentimes doesn't show symptoms. About 50% of those who develop anal cancer were asymptomatic, meaning they did not have any symptoms. And for those who were having symptoms, oftentimes, it's no longer precancer, it's actually cancer already. Another reason why screening is important because it can reduce morbidity, and mortality. We know that treating precancerous lesions in the anal canal can reduce anal cancer risk. And the 5-year survival rates for early stage anal cancer is definitely much higher compared to those who have late stage disseminated disease. So 84.5% survival rate for those who have early stage anal cancer versus 36.3% for those who have late stage disseminated cancer. So when do we start screening? Unfortunately, delayed diagnosis of anal cancer is very common. Again, there's a lot of benign conditions that can mask the diagnosis of anal cancer. That could be hemorrhoids. If somebody has an STI like gonorrhea, um, you know, um, discharge can be a symptom of both gonorrhea and anal cancer. So there's a possibility of anal cancer being missed. Again, the average age of diagnosis is early 60s, but amongst those who are living with HIV, it can be as early as in their early to mid 40s. Now, when do we stop screening for anal cancer? There's really no established guideline as to when we stop screening for anal cancer. However, the International Anal Neoplasia Society released a consensus statement last year where they said, we can stop screening for anal cancer with shared decision making if the life expectancy of the person is less than 10 years. Another consideration is decreasing the frequency of screening from every year to every 3 years. If 2 consecutive screenings, meaning 2 times that we check for anal cancer, were both negative and negative for abnormal cells, as well as it's negative for high-risk HPV, which is quite a rarity. So who should be screened for anal cancer? So when we look at the general population, the risk of anal cancer is about 1.7 per 100,000. However, some population groups have a much higher risk for anal cancer. So those are the ones that are risk category A, meaning those are population groups whose incidence of anal cancer is at least tenfold higher compared to the general population. So these are the folks that needs to have anal cancer screening. So men who have sex with men and transgender women living with HIV, we start at age 35. All other people living with HIV, we start at age 45. Men who have sex with men and transgender women not living with HIV, we start at age 45. And those who have history of vulvar precancerous lesions or vulvar cancer, we do anal cancer screening within 1 year of their diagnosis, as well as those who have immunocompromising conditions such as solid organ transplant recipient. We would do anal cancer screening 10 years post-transplant. And that's because of some of the medications that they're taking. It lowers the immune system, increases the risk for anal cancer. Now, there are also some communities that are vulnerable to anal cancer. And these are people considered to be risk category B, meaning their incidence of anal cancer is up to tenfold higher than the general population. So for people who have history of cervical or vaginal cancer, those who have cervical and vaginal precancer, those who have perianal warts, those who have persistent cervical HPV-16, meaning, if they're doing a cervical pap smear and they're seeing HPV-16 multiple times, that would be risk category B. And those who have other immunocompromising conditions, meaning those who have rheumatoid arthritis, lupus, Crohn's disease, ulcerative colitis, or who are taking systemic steroids for many different conditions, shared decision making at age 45 is recommended. So how do we screen for anal cancer? And there's basically we do a digital anal rectal exam, or a DARE, and we do an anal pap, which is an anal swab. So what is a digital anal rectal exam? What is a DARE, and what should you expect with a DARE? So a DARE provides us with a screening for early anal cancer that could be detected by palpation, being able to be felt with a finger. We perform a DARE every time someone is examined for anal cancer. The way that we perform a DARE is by palpating, meaning feeling 360 degrees of the anal canal. We basically do a circumferential sweep, feeling for any abnormal lumps and bumps in the anal canal along the anorectal ring. For those who are assigned male at birth, those who have a prostate, we would also throw a freebie there, palpate the prostate, and see if there's any abnormal lumps and bumps there. And those who are assigned female at birth, we would check for the rectovaginal septum, which is basically this wall that separates the vagina and the rectum. So if you perform the DARE well, examiners, your healthcare provider can reliably detect a lesion as small as 3 millimeters. So, for somebody who is doing this on a regular basis, this is me every Tuesday feeling for stuff. If you have a more seasoned provider who's palpating it, you can actually detect up to 3 millimeters size of lesion with really good digital anorectal exam. The sensitivity of a digital anorectal exam is about 71 to 80%, so pretty good. And the specificity of that is about 92 to 100%, which is pretty good. Again, while most cancers can be felt on a digital anorectal exam, not every anal cancer can be palpated. So again, for a clinician like myself, it's always important for us to reconcile what we're feeling with what we're seeing when we do a high resolution anoscopy. Also, something to note, the earliest cancers, earliest anal cancer called CISCA, are usually not palpable. So sometimes we can't even feel the earliest anal cancer. So in addition to doing a digital anorectal exam, we would also do a PAP, an anal cytology swab. So basically, it's a swab that we use to collect for any cells in the anal canal. Our anal canal has many, many folds. So unfortunately, right now, it's not a self-swab because if you're not doing it properly, you may not be getting adequate amount of sample. And we have a specific technique to actually do a swab. It is a blind swab, so we have to really cover as much surface area as possible when we are doing this particular type of testing. The way that we would do it, we would use a specialized swab. We moist it with water. We insert it in about 5 centimeters in the anal canal, so about 2 inches, and then we rotate it as much as possible to cover as much surface area in the anal canal. Interestingly enough, the results of an anal cytology often underrepresents the grade of the disease. So what that means is if, let's say, we do an anal pap and the anal pap is showing atypical cells of undetermined significance, it doesn't mean that there's no lesion there. There's actually a possibility that there might be low-grade or high-grade lesions in the anal canal. It's also very important to do HPV co-testing. I know that some guidelines allow HPV testing alone or an anal pap alone, and there's an algorithm that you follow. But within our organization, it just makes more sense, and I feel like we serve our patients better if we do a co-testing, meaning we do an anal pap, look for any abnormal cells, and then also look for any HPV. The combination of those two tests will give us a more not accurate, but it gives us more information about somebody's risk for anal cancer. So it gives us more data to work with when making decisions about high resolution anoscopy. Now, when you do an anal pap, and if the anal pap is showing high-grade cells, then most likely there's a high-grade lesion in the anal canal. However, if it's a negative swab, it does not mean that there is no lesion in the anal canal. So that's what it means by an H-cell cytology having a good positive predictive value. And again, an anal pap, an anal cytology swab is complementary to an anoscopy, the histology, meaning the biopsies that we do, and the digital anorectal exam. Now, in regards to the results, we follow the Bethesda system that they also use for cervical cancer screening. So for the abnormalities, there's different categories. It can be, negative. And then the second one would be atypical squamous cells. The atypical can be two different types of atypical squamous cells. It can be undetermined significance or cannot exclude a precancer lesion in the anal canal. It can be low grade, high grade, or it can also be squamous cell carcinoma, meaning cancer. So what happens if you have an L cell, like a low-grade cell in your anal pap, in your anal swab? When we look at the cells under the microscope, your cells should be in neat rows and columns. However, because of HPV, there can be disorganization in the cells in the anal canal. And depending on the disorganization, that helps us determine if it's low grade or high grade. So for low grade, there's some disorganization happening in the cells. It can be caused by both low grade, meaning non-cancerous strains of HPV, as well as the cancerous strains of HPV. For those who are immunocompetent, meaning those who do not have immunocompromising conditions, some of the low-grade lesions can actually spontaneously regress. So without treatment, it can disappear by itself, and that's the reason why we don't treat low-grade cells in the anal canal, or low-grade lesions in the anal canal. The recommendation for low-grade cells is basically close clinical observation without treatment, unless somebody is symptomatic. So unless somebody has condyloma or warts, then that's when we would treat them. Now, what if it's high grade? So you'll see that the cells are more disorganized compared to the low grade. It is caused by high-risk HPV, so those are the oncogenic types, so those are the ones that are related to cancer. And most of these high-grade cells will persist or progress. So either they remain as precancerous lesions or they will turn into cancer later on. The recommendation for high-grade cells is to treat it before the opportunity to develop into cancer. So finally, we have squamous cell carcinoma, and again, you'll see it's even more disorganized. This is basically invasive cancer. It's associated with precancerous lesions in the anal canal, and again, the goal for this is to treat it. So what happens if you have an abnormal PAP? What would we do next? So we would refer you for high resolution endoscopy, and again, I'm glad in the organization where I am a part of, we have our own high resolution endoscopy services. So if your primary care provider has an abnormal PAP, depending on the results of the anal PAP, they will place an internal referral for us to see you for high resolution endoscopy. So what is a high resolution endoscopy? It is a specialized outpatient procedure that allows us to directly visualize what's going on inside the anal canal. We don't use sedation for this. This is oftentimes used with either topical and or local anesthetic. So, when you go to the dentist and they numb up your gum, sometimes we would use the same thing. We would inject the areas, or we would just use topical lidocaine. Sometimes we would have to take biopsies depending on what we see there. So if we see any areas that are suspicious or questionable, we would take a biopsy to determine what that abnormality might be. Unfortunately, colonoscopy does not screen for anal cancer, and it's actually not an acceptable alternative to doing a high-resolution endoscopy. So lesions by region. So this is when we do the endoscopy, we look at the inside, which is going to be inside that hole, perianus, and then outside of that yellow circle. That would be more like the skin. So what happens if your biopsy is precancerous? Do you just monitor it or do you treat it? Again, the ANCHOR study really shows that treating precancerous lesions in the anal canal can significantly decrease the risk of progression from precancer to cancer. So what if the biopsy is precancerous? What we would recommend is to treat it to decrease the progression from precancer to cancer. It can be done in many different ways. It can be treated by patient-applied medication. So we can prescribe you imiquimod or 5-fluorouracil that you apply yourself, or we can apply some treatment on them, on those lesions, by using 85% TCA or trichloroacetic acid, or we can also ablate it, meaning destroy the precancer in an in-office procedure using infrared coagulation, hybrication, or laser ablation. I think I mentioned this about the importance of early detection. So this is such a great illustration of how important early detection is. So if we were able to detect anal cancer right away, if it's localized, the 5-year survival is 80%. However, if the cancer, by the time we find it, it's already metastasized, the 5-year survival decreases significantly from 80% to 30%. So as far as different treatment modalities, let's start first with topical treatment of precancerous lesions in the anal canal. One of those that are oftentimes prescribed is 5-FU, 5% fluorouracil. Again, it's a medication that can be used to treat the anal canal. Sometimes we would use it in combination with other treatment modalities. So sometimes we would use it to first debulk the disease. So if somebody has circumferential disease, meaning if you look at the anal canal and 70-80% of the anal canal has precancer, it would not be very pleasant to do hyperification or ablation on one go. I don't think my patient will like me very much if I do that. So sometimes what we would do is we would debulk the precancer first, treat as much as possible by doing self-application treatments like this, and then we would have them come in for additional treatments. Now, there are some issues associated with this particular treatment modality. It's unclear the optimal dosing for it. So some people would recommend doing application, every other day. Some people would do 3 times a week for 12 weeks. So there's really a big variation in regards to treatment modalities for this. The delivery method is also not standardized. Sometimes I worry if, I'm not a big fan of doing this particular type of treatment just because sometimes I've had patients who do a self-application and sometimes they apply it not on the right spot. So they get a lot of irritation and you're not really getting a lot of treatment. Some people are inserting it incorrectly, so it's not being delivered to where it needs to be delivered. And there's a high recurrence of precancer when you're using 5% fluorouracil as a sole treatment modality for precancer. And again, this also remains off-label for the treatment of precancer. Another topical treatment modality that we can use, this is more of a clinician-applied treatment modality. So we would have you come in, I'll use that particular solution, and I would apply it only on the area that needs to get it. We use trichloroacetic acid, TCA. We find greater clearance among younger patients compared to older folks. So when we have folks who are less than 48 years old, this might be a great treatment modality for them. Sometimes I would use it as a debulking agent. So if I have patients who have a lot of lesions going on in the anal canal, I would use TCA first to minimize the amount of lesions, and then I would have them come in for additional treatment with hyperification or ablation therapy. It's very promising. So about 32% of patients were able to clear precancerous lesions to no lesion. About 71% were able to clear precancerous lesion to low-grade lesions. And about 73% were able to clear low-grade lesions to no more lesions after application. Another treatment modality that we can use would be cidofovir 1%. I've only seen this really in clinical trials. It's been used to treat perianal precancer. So precancerous lesions within 5 centimeters of the opening of the anal canal. And even then, there's a partial response. Only about 51% have a pretty good response on this particular treatment modality. There's also a lot of issues associated with cidofovir. So number one, it's expensive. And then it's not manufactured for topical therapy. So it needs to be compounded. So it has to be sent to a special pharmacy to be put together. And again, it's not a viable option in the clinical setting just because of all the logistic issues associated with this particular treatment modality. The one that I prefer and the one that I've seen a lot of success with is outpatient ablation of precancerous lesions in the anal canal. So there's many different types of ablation that we can use. We can use infrared coagulation, we can use laser, We can use radiofrequency ablation. We can use electrocautery, using low voltage electricity to zap off the area that needs to be treated. That's also called hyphication. And they're pretty much equivalent when you look at the comparison between the different treatment modalities. I'm more of a fan of hyphication just because of um, the hyphicators. The blade that I use for using this particular treatment modality is pretty small, so I'm able to really apply the treatment only on the area that needs to be treated. Meaning, I can minimize the swelling, I can minimize the bleeding, and again, I'm only applying it on the area that needs to be treated, so I leave the healthy tissue behind. Very tolerable for many of my patients. And then as far as the success, if you're using infrared coagulation, about 72% were able to get rid of the lesion at the first get-go, versus hyphication, which is 75%, so very similar. As far as recurrence, 59% recurrence with infrared coagulation and about 49% recurrence with hyphication. So very similar. There's no statistical difference between the two. But if you're looking at just absolute values as far as like percentage is concerned, hyphication is higher than infrared coagulation. So now what do you do if the biopsy comes back as cancer? So if it does come back as cancer, that's beyond my scope. So I would have to connect you with an oncologist. At that point, cancer stage to determine the treatment approach that will be done to treat it. In the past, surgery was the only way to cure anal cancer, but today there's a lot of different treatment modalities. Radiation and chemotherapy can be viable options, and oftentimes surgery is not needed for anal cancer treatment. And again, importance of prevention and early screening. Anal cancer is very treatable. However, the treatments associated with anal cancer, it really does affect quality of life issues. So for those people who uses, their anus as a sex organ, it definitely can affect intimacy for a lot of people. It can cause, radiation, can cause incontinence for some individuals. So erectile dysfunction can be an issue. Um, just a lot of issues associated with the after effects of the treatment itself. So again, if I could not emphasize it even more, early prevention and early screening is very, very important. So what are some of the misconceptions about anal cancer? Oftentimes, anal cancer is lumped together with colon cancer, but they're quite different. So the cause for colon cancer is different from the causes of anal cancer. The treatment modality is different. The screening is quite different. So they are different types of cancer. There's also a misconception that, even though bottoming increases the exposure to HPV and this, increases the risk for anal cancer, anyone can get anal cancer, even those who have never had anal sex. So, bottoming is not, it just happens that bottoming is a lot of friction involved. So there's a lot of skin to skin contact involved. But bottoming is not it does not the cause of anal cancer. Also, there's a misconception that men, especially gay and bisexual men, get more anal cancer. However, as I showed earlier with the statistics, women, especially those who are over 50, have higher rates of anal cancer. 68% more new cases in 2024 among cisgender women. Also, while people living with HIV are disproportionately affected by anal cancer, those who are not living with HIV are also at risk. So again, I showed some risk categories, immunocompromising conditions, history of cervical cancer. Those individuals are also at risk for anal cancer, even if they are not living with HIV. Also, those who have been diagnosed with HPV, human papillomavirus, should still be considered for HPV vaccine if they meet the age recommendations. And again, if they do not meet the age recommendation, if they're above age 45, it's shared decision making between the patient and their primary care provider or their provider. So I also want to talk briefly about stigma-related barriers. We oftentimes see that, stigma plays a very important part in preventing people from being screened, and we know that screening can save lives. Oftentimes, patients may be uncomfortable talking with their healthcare provider about their anal health. And also at the same time, healthcare providers may be uncomfortable asking their patients about sexual health practices. So, it is a relationship. So I think having a trusting relationship with your healthcare provider is very important. Being able to really talk about your sexual practices about your healthcare provider is a way for you to also decrease your risk for conditions, anal cancer being one of them. So again, talk to your healthcare provider about your sexual health practices, ask about anal cancer screening. That can definitely save your life. And I think that concludes go ahead.
Thank you so much.
Thank you so much for the presentation. I just had an anoscopy this morning at 9 a.m. and I also have 3 years of sobriety today, and I was getting my anoscopies from is it Matt Moran and Benjamin Hernandez before.
William Hernandez.
A lot of the acid treatment and all those things that you had on one of your slides. They used to do that to me every year, and today I was in and out in 30 minutes, and that included getting undressed, the procedure, getting dressed, making my appointment for a year from now, and she said it was Carrie Sotomayor, I guess at Eisenhower, and it was my first visit with her, but there were no procedures like I'd done in the past, but I do remember one of your earlier slides said that some of those things go into regression. But I'm just curious, does that area heal itself that quickly? Or like I feel like I didn't get a thorough exam, even though I know she has clients lined up for 9 months and a lot of people go to her, but my experience today was so simple and easy compared to the 10 years in the past where I've gone every year, and I used to have to go even twice a year. You know what I mean?
Yeah.
So it was a great exam. I'm just like, how come all the times before they always found something, but today they didn't? But I'm glad they didn't. But in my head, I'm like, look deeper, look further. Anyway, I appreciate your presentation. Thank you.
Thank you. Yeah, I mean, it really depends, right? It depends on what they see on the examination. So if somebody had, we don't want to do any treatment for a questionable lesion that we don't know what it is, right? So it could be just a benign thing. We don't want to treat it and cause more harm if it's benign. So the way that I couldn't really speak to other clinicians' approach to things, but my approach to things would be if somebody comes in for a high resolution anoscopy, we would do a digital anorectal exam, we would do an anal pap, and then we would look at the anal canal using a high resolution endoscopy. So along the squamocolumnar junction, that's just a fancy term indicating that there is it's an area between where the anus meets the colon, essentially. So we look at that area, we pull out, we look at the perianus, we look at the outside of the opening. So we look at that, we do a thorough evaluation and seeing if there's any questionable lesions that needs to be biopsied. Now, if there's nothing there that needs to be biopsied, that's a good sign. Regardless, I do a follow-up with my patients, whether they've had a biopsy or not 2 weeks after, to go over the results of their anal pap. Based on the result of their high-resolution endoscopy examination, along with the result of their anal pap with the HPV co-testing, we'll be able to determine, do I need to see you in 6 months? Do I need to see you in 1 year? What would be the next steps for us? Do I need to do a high-resolution endoscopy for you? Or is your anal pap all negative, meaning negative cells for abnormalities, negative HPV, your exam was negative, it's been negative for the past 2 years. Do you need an endoscopy next year? Maybe not, maybe just an anal pap with a digital anorectal exam. So it really depends on what we see and the results of what we collected during the examination.
Is there a difference in anoscopy and a high resolution anoscopy, or are they always a high resolution?
Yeah, so that's a really good question. The question was, is there a difference between an anoscopy and a high resolution anoscopy? So an anoscopy is when somebody just uses a scope, they insert it in, they look without using any other machine. They try, well, it's really hard to look anyway. So it's, you know, I don't do an anoscopy without doing a high resolution anoscopy. I think it's kind of like a waste of time to do that. If you're gonna insert something, you better look, right? So yeah, so that's the difference. Using your eyes versus using a machine to really magnify things to see if there's any abnormalities there.
Don't
Yep.
try it with your iPhone. Yeah, and to your first question, I would say that not all clinicians are equal. And anecdotally, I've heard people are not satisfied with tracing model and heard some
Really
stories.
quick, but she had like 3 or 4 people,
Yeah.
women. So
So at Eisenhower, they did have John Colbert, who was kind of leading
yeah.
that department, and he left. He's now at Desert Oasis, and so it's just her, so that's why she's back up, because there's people to do it. So if you're not
I'm
satisfied,
with Desert Oasis, and I heard there was someone at Desert Oasis, so it's probably him, right?
John Colbert, he is seeing
But I
patients
already
now.
had my appointment for
Oh.
like 9 months with her, so I didn't want to wait 9 months for
Hmm.
the guy at
Yeah.
Desert Oasis.
He's
probably-
now there.
probably
In fact,
the
I'm
guy
seeing him
that-
on Wednesday.
Yeah, I
So
think
if you're not happy with that, say
I
you
think
have
I'm
good
happy.
service.
I just, I've had that acid treatment that was on one of your slides. You listed like 3 things, and all those things were done in the past.
Mhm. Yeah.
But if you have concerns or are not, I would ask him if you could get in to see Dr. Colbert as well. Yeah. Since you Desert Oasis.
I think the challenge too is, there's not a lot of folks who are trained to do high resolution endoscopy. So as I was building the program, I've had a position posted for like a year and a half with no applications. So it's actually hard to recruit somebody who's already trained doing this particular specialized procedure. So for us to be able to meet that gap, I trained my own. So now at the AP Health, we have 3 endoscopists now. So in the past year, yeah, so it's challenge. But we have 3 endoscopists now. I'm training 1 more person, hopefully another one. So hopefully we'll be able to actually provide high resolution endoscopy 5 days a week. So that will definitely significantly decrease the wait time for folks.
Getting from Desert Oasis.
I was informed that yes. Yeah. Yeah. Yep.
So he's saying Jorge Rodriguez at Eisenhower is also starting to do them.
Oh, great.
Because I think he did them in private when he was in private practice in LA. Yeah, so one more option, but yeah, you have to call this.
Yeah, we definitely need more.
System or how that works.
Yeah, we definitely need more people. That's one of as the director of our division, that's my goal, is to really improve access for high risk. It's needed. And now, with the guidelines being published last year, more and more people are actually screening, which is a great thing. But also at the same time, it's really, a lot of people are screening, but a lot of people are now having to wait to have the procedure done because not a lot of people are able to do the procedure. I just had a meeting with a colorectal surgeon who is moving here in the desert, I believe in July, from Las Vegas. About 30% of his practice in Vegas are part of the LGBTQ plus community, which is very reassuring. So I met with him, I feel comfortable referring to him for more advanced evaluations, treatment of anal cancer, things like that. So if I'm going to be if I'm referring my patients to somebody, I like to refer my patients to somebody who I trust and I know my patients will be comfortable seeing. So there's more people, I'm glad, that are coming to the desert to do this type of work.
Well, and a huge debt of gratitude to you for, taking it upon yourself to train people. This
Oh,
is not a
thank you.
glamorous specialty. So
No.
But you have to be a DAP client to come and see you?
No, I've had patients from other organizations who've sent a referral to see us. Um, so we accept external referrals.
And then the colorectal surgeon for Vegas, is he gonna be
Desert Regional.
Desert Region?
Yeah, Dr. Tonki.
Yeah, I'm recently moved to Palm Springs. And I've had my primary has sent you guys referrals for myself and my partner. And we haven't gotten any phone calls back from you. Every time we call, they say, we don't have it, we can't find it. So anyway, the last 9 months I've had 3 biopsies cut back with squamous cell.
Mm.
So I've been trying to get into some contact with somebody here, but it doesn't seem to be working.
Yeah, let's definitely connect. I know that our referral services are being upgraded right now, so that might be part of it. But what I anticipate is, again, I think our third anoscopist just got fully trained just a few months, like maybe a month or two ago. So it's fairly new. So we anticipate that so before I had the other two, my wait time was like 9 to 11 months. So I think we're in the process of kind of like moving things. What's really nice now, though, is I'm able to, for those who had precancerous lesions in the anal canal, I've been seeing that I'm able to treat their precancer within like a month before, like people are waiting like much longer. My goal is to treat it within like 2 weeks.
Right.
It's moving.
Get a colorectal surgeon now. Because I can't see.
Hmm. Yeah, well, let's definitely connect after the presentation and I'll help navigate things for you a little bit.
Alice has been patiently waiting online. He asked if the vaccine is considered to be a good thing to enhance one's immune response to the 9 strains of HPV, and how expensive is the course of free vaccinations?
Yeah, so the last time I heard, if it's not covered by insurance, it's about 200 something dollars per dose. So it's about $600, and that's with 340B pricing.
Okay, so that's 340B pricing.
Yeah, I don't know how it is in like other retail pharmacies.
And then he also asked about rectal squamous cells, whether they're the same or very different from squamous cells of the head and neck.
So rectal cancer is different from anal cancer. The depends on the head and neck cancer. So the head and neck is quite a big category, but there's also a squamocolumnar junction in this part of the body, and it can also be caused by HPV, the cancer in that particular part of the body can also be caused by HPV.
So given, it seems like it's more common now, you hear a lot more about
Oh.
HPV-related cancers. What kind of screening should people be doing for those?
So right now there's no FDA approved screening for that particular type of like throat cancer. The only one that we're doing right now, HPV related cancers would be cervical cancer and anal cancer. And yeah, Dr. Ardismo. Yep, everybody knows Dr. Mo. Yeah, she's awesome, and yeah, I'm glad that she's training new HRA practitioners there. There's other areas of the country that are also doing training. I know that I think Chicago, can't remember the name, Laser, I think it's called, have started doing their training there as well for high resolution endoscopists. They have a curriculum that they're developing.
Yeah, one of the things that came out of the Anchor study is that it was a nationwide study, and to do it, just with Anthony, Matt Moran, and others here in the desert, John Colbert as well, all got trained as a part of that. So it really kind of increased the capacity across the country.
Yeah, and what's really nice about that too is it's a very robust training process. So they really come in and they check how you're doing the procedure. So there's really a high standard, making sure that the way that we are doing the procedure, the way that we're treating precancerous lesions in the anal canal is aligns with the International Anal Neoplasia Society guidelines.
One is just a statement. Is it true, Farrah Fawcett and what's her name from Cheers, Kirstie Alley, that they both died of anal cancer? And also, wasn't it Dr. Wiley that used to come and do some type of study at DAP?
Oh, Dorothy. Yeah. Yeah.
I was part of that. I was just curious whatever happened to that study.
Yeah. I think the clinical site over at UCLA, I think you're talking about Dorothy Wiley, right? I think that the site closed also, the UCLA School of Nursing site closed during the Anchor study. But the care center at the time still had an active site. I think Dr. Wiley is still doing some studies on HPV, but we haven't connected in a while. I think that's still ongoing, not specific what kind of study though.
Yeah, so the Anchor study was happening at DAP, and that was happening at DAP. Exactly. She and Matt Moran were doing seeing patients because I was in that study as well. And then DAP was in the Anchor study. Sadly, towards the end, Dr. Morris decided to drop the study, so they sent their patients to LA, those who were able to go. But yeah, but like I said, the training was really awesome. Other questions?
So there is a relationship between anal cancer, rimming, and oral cancer?
Oh, that's a good question. I haven't read any recent studies about it, but I've actually, that has been a conversation in the scientific community. Yeah, but I haven't seen the data on it yet.
Marcia Cross, so Desperate Housewives, is the other celebrity who was public with her diagnosis of anal cancer a few years ago. Other questions? If not, thank you so much.
Thank you, everybody.
People may remember that years ago we had Joel Palevsky, who was kind of the godfather of all this research. So did the Anchor study, came and presented here a couple of times, I think. We present this occasionally over the years. So great to have Anthony following his footsteps and to continue the tradition. So a couple of announcements. Later this month, on the 19th, we're going to be doing our first self-advocacy and HIV and self-advocacy and healthcare conference. It's going to be at the Mizell on Saturday, the 19th. So please come out, check your inboxes. We'll be sending out the invitation soon. And then next month's program is going to be a CROI update.
9 to 3.
At 9 to 3 on Saturday, the 19th. And then next month's Positive Life will be a CROI update with Kathy Chen from Gilead. She's an amazing presenter, so come on down. She has a unique ability to kind of break down the science into really easy to understand terms. So we're looking forward to her talk. So we'll see you then.
Free lunch.
Yeah, free lunch at the advocacy conference. Great, thank you all. Have a great evening.
Thank you, everybody. Good night.